We described the PK/PD of antimicrobacterial agents differentiated between latent TB and active pulmonary tuberculosis. We initiated a medication regimen in patients with latent TB, and we recommended guideline concordant first-line therapy for patients with pulmonary tuberculosis. Now, given a tuberculosis patient case, let's evaluate and manage drug-drug interactions. Majority of drug interactions are due to rifamycins. So in general, rifamycins are inducers of CYP enzymes. Now, rifaximin is not absorbed, so it's not used for TB, and because it's not absorbed, it doesn't really lead to any major drug interaction. But the other three rifamycins that are systemically absorbed and are used for tuberculosis can lead to drug interactions. Now, when we compare the three of them, rifampin is a very strong, potent inducer of CYP enzymes, including CYP 2C9, 2C19, 2D6, and 3A4. And this induction typically takes about 1 to 2 weeks to kick in. So it takes about 1 to 2 weeks for these CYP enzymes to be overproduced. And then upon discontinuation of rifamycins, it typically takes 2 weeks for this induction to wane away. So if a dose of a drug is increased to compensate for rifamycin effect, it is critical to reduce the dose within 2 weeks after rifamycin discontinuation. Rifampin is hepatically metabolized. It is not a substrate for CYP enzymes itself, and it doesn't need to be renally adjusted. It can also induce P-glycoprotein, so that's also one of the reasons for drug interactions. So in general, Hiv protease inhibitors, non-nukes, and anything that's a boosted regimen interacts with rifampin because it's a strong inducer. Now, when we look at rifabutin, it is also a substrate of CYP3A. So rifabutin, you have to watch out if you use it with anything else that either inhibits or induces CYP3A. So rifabutin itself does auto-induction of CYP3A, and rifabutin is the only rifamycin that's actually renally clear, so it does need to be renally adjusted if creatinine class is less than 30. Now, if we consider rifampin's potency of induction at 100%, rifabutin would be at 50%. So it's not as strong of an inducer, so it's considered a moderate inducer of CYP enzymes, so that could be one thing to use to manage some of these drug interactions. And rifampin's induction is between rifabutin and rifampin. So rifampin is the strongest one, then rifampin, and then rifabutin. Now, isoniazid is hepatically metabolized and it is not renally clear, so no adjustment. It is not an inducer, but it can inhibit 2C19. So this inhibition, which is actually moderate, can lead to some drug interactions, including isoniazid can increase the levels of phenytoin as well as carbamazepine, and it can prevent the activation of clopidogrel. So clopidogrel is a prodrug that needs 2C19 in order to be activated. Now, these interactions are if you are using isoniazid alone. If you are to use isoniazid in combination with rifamycin, these interactions actually flip to the other side. So when used in combination with rifampin, for example, which is a potent CYP inducer, the concentration of these medications are actually decreased instead of increased. Pyrazinamide needs to be renally adjusted with creatinine class less than 30. It doesn't induce or inhibit any enzyme, so it doesn't cause any significant drug-drug interactions. The same is true with ethambutol. So it's renally adjusted with creatinine class less than 30. It's hepatically metabolized and no induction or inhibition of CYP enzymes, so no significant drug-drug interactions. So because rifamycins cause the majority of interactions, let's explore some of these interactions. So when it comes to Hiv protease inhibitors, these protease inhibitors are strong inhibitors of CYP enzymes. So for these patients, rifabutin is preferred. And that's because rifabutin has the least amount of induction which can, you obviously need a booster for these agents, so you don't want to induce the CYP enzymes too much. Now, rifabutin itself is a substrate of CYP3A, so the dose of rifabutin needs to be decreased when used in combination with protease inhibitors. Efavirenz is an inducer, so for efavirenz, rifampin is actually preferred over rifabutin because rifabutin itself is a substrate of CYP3A. With rilpivirine, which is a substrate of CYP3A, cannot use rifampin or rifabutin. With raltegravir and dolutegravir, you can actually increase the dose of either raltegravir or dolutegravir with rifampin, or alternatively, you can use rifabutin and use the normal dose with these two, so that's manageable. Elvitegravir is boosted with cobicistat, so do not use with rifampin. Rifabutin can be used. Clarithromycin is a strong inhibitor of CYP3A4, so it may increase the rifabutin, which is a substrate of CYP3A4, to toxic level, so it's not recommended. And with doxycycline, it's shown that rifampin lowers doxycycline AUC by about 50%, and the mechanism is not really known, but it's best to avoid doxycycline. Azoles, with the exceptions of fluconazole, typically will have low levels if used with rifamycins. So fluconazole is not as strongly dependent on CYP3A4. Atovaquone has been shown to have subtherapeutic levels when used with rifamycin, so an alternative agent should be used for PCP. When it comes to oral contraceptives, because they are metabolized by CYP3A4, a second barrier method of contraception will be needed, for patients who are of reproductive age. For many of these, the interactions are manageable. So with levothyroxine, you can actually monitor TSH, and based on that, you may need to increase the dose of levothyroxine. With methadone, methadone basically is metabolized by many of the CYP enzymes. So an inducer a strong inducer can reduce the level of methadone, and methadone, is often used for opioid dependence. So these patients, might develop withdrawal symptoms. So if that happens, the methadone dose is typically increased. Alternatively, it's best to use rifabutin instead of rifampin if someone is on methadone. With warfarin, obviously you just monitor INR, and based on INR you can adjust the dose of warfarin. The same is true with cyclosporin and tacrolimus, which are drugs used for transplantation. We can get levels for these drugs, so therapeutic drug monitoring can help. The same with phenytoin and lamotrigine. We can get drug levels and do therapeutic drug monitoring. The same is true with digoxin.